Hello, everybody, and thank you for joining me today. My name is Gregory J. I'm the Director for Clinical Microbiology at Columbia University Medical Center. And today I want to talk to you about a really important topic from both the laboratory and the clinical perspective, and that's neonatal health. And specifically, we're going to talk about the impact of Group B Streptococcus screening, molecular-based or NAAT-based detection, and also prophylactic interventions and how these play into the overall workup for Group B Strep. And so today, the program objectives are going to be, first and foremost, we want to review Group B Strep. We want to talk about causes of Group B Strep, risks, and the symptomology. Then we want to transition to guidelines and talk about guidelines from ASM and ACOG. And then we're going to discuss diagnostic testing methodologies. We're going to talk about culture, and specifically also we're going to talk about nucleic acid amplification testing, and you'll see that term NAAT, N-A-A-T, over and over again, which is short for molecular. And we want to talk about screening success stories, both in the United States and across the globe. And so to start with a brief GBS overview. So Group B Strep is scientifically known as Streptococcus agalactiae. And for short, we'll use GBS today. And this is a gram-positive cocci if looked at on gram stain. So gram stain is a common stain that is done in the clinical microbiology laboratory. And this means that it basically is a spherical cocci that is usually in pairs or chains, and it appears purple on a gram stain. And this organism is a commensal that is both found in the GI and the urogenital tracts, in places like the digestive system, the urinary tract system, and the female reproductive system. But although it is a commensal organism, it's also a really well-known opportunistic infection, which could cause infections in many different tissue types, including skin and soft tissue, bone and joint. It can cause pneumonia. Of course, it can cause bacteremia, bloodstream infection, and meningitis, as well as others. And specifically today, I want to focus in on Group B Strep during pregnancy. So during pregnancy, Group B Strep can asymptomatically colonize both the urinary genital tracts and the gastrointestinal tracts. And in fact, this is estimated to be the case in 10 to 30% of pregnant women. So 10 to 30% of pregnant women are colonized with Group B Strep. And this prevalence can range by geographic region, by race, and by other factors. But importantly, approximately 50% of pregnant women who are colonized with GBS can transmit the bacteria to their newborns. And so this is really an important point because 1 to 2% of newborns that acquire GBS during pregnancy or birth can develop GBS early onset disease in the absence of antibiotic prophylaxis. So we're going to talk a lot more about that. We have vertical transmission, which is ascending during pregnancy, or ascending during labor, or inoculation as the baby passes through the birth canal. There's also horizontal transmission, and this is the idea that once the baby is born, the baby can pick up Group B Strep either from the mother or from a hospital or community environment. And furthermore, as we delve into Group B Strep during pregnancy, there really are infections that are really well known that can cause complications in Group B Strep. Before birth, manifestations are things like urinary tract infections in the mother, as well as more severe manifestations of bloodstream infections, including sepsis, as well as intraamniotic infection or endometritis. And obviously these can cause major complications, leading from everything from a preterm delivery even to a stillbirth. And then of course there are then infections that are found in the actual newborn, which is what I want to talk about next. So those are complications during pregnancy, and now we can talk about just after pregnancy in the neonate. So following birth, we move into the postpartum phase of Group B Strep disease in the newborn. And there are a host of different symptoms that can be associated with active GBS disease. And some of the symptoms are listed here. It's not an all-inclusive list, but many of the symptoms are here. Fever, difficulty feeding, urinary tract infection, irritability or lethargy, difficulty breathing, or bluish-colored skin. And when we talk about disease in the newborn, we can really think of two phases of disease that are based on timing and the typical route of infection, right? So these are early onset disease and late onset disease. And when we think about early onset disease, this is vertical transmission during labor or birth, and it presents in babies that are less than 7 days old. And then there's late onset disease, which is horizontal transmission from the mother or the environment, and that presents from day 7 to 89 days old. So this is basically 3 months out. And both early and late onset disease can manifest as bacteremia, sepsis, pneumonia, and meningitis. So some of the risk factors when we think about early onset disease, and our focus is going to be early onset disease today because early onset disease is what is considered to be the stage that is most effectively handled by using antibiotic prophylaxis. So it's really important to recognize group B strep as early as possible. And when we think about that first 7 days, this is where we're trying to avoid that early onset disease. And so when we focus in on risk factors for early onset disease, the primary risk factor is maternal colonization of the genital urinary or GI tract in a current pregnancy. Also, importantly, women with a history of GBS colonization in a prior pregnancy have a higher risk of being recolonized in subsequent pregnancies, with the statistics being about 50% of women thought to be recolonized. And some of the risk factors that are other than the primary risk factor also include things like maternal risk factors, a young maternal age, maternal black race, previous child that has early onset disease, or group B strep bacteriuria during any time during a pregnancy. Intrapartum risk factors include things such as interamniotic infection, intrapartum fever, preterm, pre-labor rupture of membranes, and prolonged rupture of membranes. And neonatal risk factors include things like a gestational age of less than 37 weeks, so a premature birth, and a very low birth weight. And when we think about the consequences of group B strep disease in neonates, 4 to 6% of newborns who develop group B strep disease die. And the babies that do not end up dying also have really high potential to end up with long-term adverse health outcomes, including vision loss, hearing loss, developmental disabilities, and even cerebral palsy. So these lifelong sequelae are major public health implications in neonates. So all the scenarios that can occur during group B strep infection are basically starting with colonization of the mother. So if you have a situation where the mother is colonized, the most important thing that we're trying to avoid is that colonization leading to disease. So the overall outcome that we're looking for is a healthy mother and child. If we do get colonization that leads to an infection in the mother, we look at things like maternal sepsis, right, which can lead to either maternal death or maternal impairment. Then we think about the other side of the equation, which is the neonate, right? So in the neonate, we can have transmission of infection, which can lead to either early or late onset disease, things like meningitis and sepsis. And while these can be alleviated through treatment in some cases and lead to healthy child development, neonatal impairment and neonatal death are also very high on the differential in both early and late onset disease. In utero infections are another issue that occur and typically can lead to the same type of outcomes, right? Either a stillbirth in the third trimester, or it can lead to things like neonatal encephalopathy or preterm birth. While these can potentially lead to healthy child development as the best outcome, frequently they do not, and they lead to the sequela of neonatal impairment and neonatal death. So the whole point of the potential outcomes is to avoid basically the colonization moving into any type of infection and either decolonize to lead to a healthy mother and child. So how do we do that? Well, it's been shown that GBS intervention, the best thing we can do to lead to risk prevention is intrapartum antibiotic prophylaxis, or IAP. So what is IAP? IAP is the administration of intravenous antibiotics to pregnant women during labor to prevent the transmission of group B strep to newborns and reduce that risk of early onset disease. And the clinical utility of that is an effective intervention to prevent early onset disease in neonates with effective strategies to prevent late onset disease, unfortunately at this point not having been identified. So it's really important early on from the clinical utility side to make sure that that early onset disease is recognized because of the fact that we know there's a risk factor there, which is the mother being colonized. And if the mother's colonized, we could move to avoid early onset disease in the first place. Now I'd like to delve into the different guidelines that are out there that have been developed to prevent and manage group B strep disease. And first and foremost, this has been a collaboration amongst the CDC and several different societies, dating back to 1996 with the CDC publishing the first recommended group B strep screening in collaboration with several different professional societies. And as time has gone by, today the societies that are currently covering the guidelines are really split into the clinical guidelines and the laboratory guidelines. So in the clinical guidelines, we have the American College of Obstetricians and Gynecologists, or ACOG. We have the American Academy of Pediatrics, which is AAP, and they write the guidelines on prophylaxis and treatment for GBS infection in pregnant women and newborns. And then we have the laboratory guidelines. So these are the guidelines that would basically function as a guideline to tell the laboratory the best way to identify group B strep. So we'll start with the ACOG prophylaxis and treatment guidelines. And this is published as an ACOG committee opinion back in February of 2020, looking at the prevention of group B strep early onset disease in newborns. And the guidelines for early onset disease prevention really highlight how important IAP is and how effective it is in avoiding early onset disease. And so when do we use IAP and when do we not use IAP? Well, IAP is indicated in many different scenarios, which are laid out here. One is the maternal history. So if you have a previous neonate, if the mother's had a previous neonate with invasive GBS disease, IAP is indicated. In the current pregnancy, if there's a positive maternal screening test, so a group B strep positive by culture or by a molecular test that with at the greater than 36-week mark, a IAP is indicated. So you have a positive GBS result in that window. Group B strep bacteriuria, so bacteria in the urine, GBS, the mother's urine at any trimester, IAP is indicated because it can obviously be transmitted to the neonate. Also in the intrapartum, if there's an unknown group B strep status at onset of labor, and any of the following, right? So this linked with any of the following: a gestational age that's less than 37 weeks, amniotic membrane rupture at greater than 18 hours, a maternal fever of greater than 100.4, intrapartum GBS NAAT result that's positive, so a test that's done on the spot and is positive. Also a test that is done at almost at point of care or at time of delivery that's negative, but there's still risk factors because we know there's a sensitivity issue with that, which we'll talk about moving forward. And unknown GBS positive status in a previous pregnancy. It's really important. IAP is also indicated. So that's when it's indicated. When is it not indicated? So IAP is not indicated just because there's a maternal history of GBS colonization. So colonization without disease, just because a mother was colonized doesn't mean the mother is still colonized, and it wouldn't be an automatic IAP. There needs to be follow-up testing to see the current pregnancy. And so the question is, the current pregnancy, if a negative group B strep result is given at greater than 36 weeks, we know that GBS is not present, and so IAP would not be indicated. Also, if there's a cesarean birth performed before labor onset and the amniotic membranes are intact, regardless of the GBS status or gestational age, IAP is not indicated because the baby is not passing through the birth canal. Now to intrapartum. So if you have a negative GBS status at greater than 36 weeks, regardless of the intrapartum risk factors, IAP is not indicated. Now we talk about unknown GBS status. So there's no testing, right? So an unknown GBS status upon onset of labor with a negative molecular test and no interpartum risk factors. And the risk factors would be a gestational age of less than 37 weeks, amniotic membrane rupture at greater than 18 hours, or maternal fever. If these are not present, IAP is not indicated. And ACOG also covers a lot of other specific scenarios on the clinical side, things such as management of preterm labor, group B strep bacteriuria management during pregnancy, management of PPROM, and planned cesarean birth. These are all covered in the ACOG guidelines, and they're a wealth of knowledge for these various topics. So definitely refer to them as any of these topics would come up. And so when we think about the best regimen or the recommended regimen for IAP, by far the go-to is penicillin, right? So penicillin is the go-to because GBS as a whole is almost always sensitive to penicillin. And so it is the go-to. Importantly, though, when we think about IAP, well, 8 to 10% of pregnant mothers who are colonized or group B strep report a penicillin allergy. Now, that can range from anything from a allergy that's like an IgE-mediated response. These can be things like, we'll go over them, in fact, in more details, but there's a lot of different scenarios where maybe penicillin would still be warranted. And so, okay, so we go down the route of allergic to penicillin and say unknown risk. Okay, so there's no information about antibiotic choice. The first thing that would happen is the mother, we don't know how much of a risk it is. We would do a penicillin allergy test. The fallback would be either cephalosporin or clindamycin if we get sensitivities, or vancomycin. If there's a low risk, it's cefazolin, so we go to a cephalosporin from penicillin. And if it's a really high risk, and again, we'll talk about those details, the high risk is going to be a clindamycin sensitivity that's done on that positive GBS culture, right? And if it's resistant, then it's going to be vancomycin, and if susceptible, then clindamycin. So clindamycin, if resistant, then vancomycin. And that kind of brings us to the laboratory guidelines. So we detect all of these things in the lab, right? Well, we detect group B strep in the lab. We do the antibiotic susceptibility results in the lab. So let's talk about the ASM laboratory guidelines. So these are the guidelines for detection and identification of group B strep, which were released in 2020 and then updated in July of 2021. And so the ASM guidelines for group B strep and screening really span from collection all the way up to when we would need an antibiotic susceptibility result and when we wouldn't. So let's start with collection, storage, and transport. So if we want to maximize group B strep recovery, we're going to use a single swab that's a dual site sample of the vagina and the rectum. So this is a vaginal rectal swab. It's going to be a flocked swab, and this is going to be transported to the laboratory in non-nutritive liquid media and transported to the laboratory within 24 hours. And in order, once that arrives in the lab, to maximize group B strep detection, we're going to incubate that in a selective enrichment broth prior to plating or doing a molecular test. And this will include both hemolytic and non-hemolytic strains in detection. It's important that your system needs to be able to detect both, and we'll talk more about what that means. And in urine, any GBS, as we had discussed before, gets reported in any quantity in any trimester because GBS in the urine would, of course, indicate colonization, and colonization can always be the risk factor leading to spread to a neonate. And so in order to identify then group B strep, there are molecular-based or NAAT-based identification directly from enrichment broth, and that's an acceptable identification method with reflex to antibiotic susceptibility testing if needed. And there are also phenotypic and proteomic ID methods, things like the CAMP test, latex agglutination, and mass spectrometry. And latex agglutination direct from enrichment and direct from specimen is not acceptable, and that's important. So the first two, either a NAAT or a phenotypic-based approach, but direct from enrichment broth is not acceptable. And then AST. So if we need antibiotic susceptibility testing, we're going to perform AST on all GBS isolates from women who have a severe penicillin allergy. Because if they don't have an allergy, if the mother does not have an allergy, there's no reason to branch from penicillin because it works great. But if they do, you need the backup drug, right? And so the backup antibiotic we need is clindamycin. And clindamycin is preferred as the antibiotic for women with a severe penallergic response. But the issue is there is resistance, right? So susceptibility needs to be done to see if clindamycin will in fact work. Because if clindamycin doesn't work, the fallback will be vancomycin as the next fallback. And so the workflow for GBS screening is first the lab is going to receive that swab, right? That's transported within 24 hours at room temperature. And the lab is either going to put this on, either going to do a differential selective enrichment or a selective enrichment. So let's start with a differential selective enrichment because it's on the left-hand side, and we'll walk down that first. So in differential selective enrichment, you basically have a situation where the media can do a color change, right? And so that color change in the presence of beta hemolytic group B strep can actually lead to a pigment color change that can lead to a group B strep being identified directly from the color change. We'll talk a bit more about that. There's also a situation where there's no color change, right? And so it would be nice if that was 100%, but it's not, because beta hemolytic strains are the only ones that make a color change. The non-beta hemolytic that can still cause disease would fall into the no color change, which means it has to be backed up by culture anyway. So at that point, we fall back into culture, and then we're going to follow the same chain down through culture, through a subculture, and through identification. So now we go to a selective enrichment. So this is the swab now coming in with the liquid being put into a selective enrichment media, which is meant to help grow group B strep and cause the growth of non-group B strep to be less, and we'll talk more about that. But that selective enrichment needs to get incubated for 18 to 24 hours, so basically till the next day. That then gets put in culture, and culture can detect both hemolytic and non-hemolytic strains. So that's important, right? So that's the Achilles heel of the differential selective media enrichment. That's not the Achilles heel of the selective enrichment. So culture will catch everything, right? Well, in culture, you're going to do a subculture if you need to, if you can't pick it directly from the plate. And then once you get a purified colony, you can do biochemical testing. You can do latex agglutination with biochemical testing, or you can do multi-TOF. And multi-TOF is mass spectrometry. So that's mass-assisted laser desorption, ionization, time-of-flight mass spectrometry, everyday use to ID organisms, pure organisms in the laboratory. And once we have that identification, then of course we can issue a report and GBS is identified. If AST is needed, so if antibiotics are needed because the mother is severely penallergic, then of course it needs to get set up for AST testing, and we'll talk more about that. The third route that you can see is coming off selective enrichment, and that leads over to the right-hand side, which is this light blue box. So this goes right to an FDA-approved molecular test from enriched culture, and this can be done in a few hours and can lead to a positive result getting issued. If antibiotics are needed, antibiotic results are needed, then what we're going to do is we're going to reflex that to culture, and we're going to then provide that the next day. I think importantly, and why I kept it for last, if you go all the way directly over to the right from the top, from the lab receiving, direct from patient NAAT is not recommended because it's not sensitive enough, right? So that enrichment step needs to occur before any workup of GBS can be done, because it's just not sensitive enough to pick up many of the cases. And even if it would pick up many of the cases, the issue is that it will miss cases, and so you will lack that sensitivity that's so important in a screening test. And so now on to the different methodologies for diagnostic testing. So talking more about the laboratory and what is done in the lab for GBS identification. And so when we think about the traditional workflow in the lab, we get that swab, and we just talked about this, right? We have the differential enrichment that has a color change. But unfortunately, no color change still leads back. All roads lead to culture in this case, right? So we have differential enrichment or selective enrichment. In selective enrichment, we get the culture, which we could identify both hemolytic and non-hemolytic strains. If no candidate isolates are observed, the plate is held for another 24 hours. So we go from 24 to 48 hours, and then we look. And if we can find a colony that looks like group B strep visually on the plates, that's when we're going to do our biochemical or our mass spectrometry type of testing in order to ID it. And so we keep on talking about selective enrichment. So what is selective enrichment? These are broths, actually, that inhibit the growth of other organisms that could potentially just overgrow group B strep and basically hide it from the laboratory technologist trying to identify it on a plate. And so these broths typically inhibit the growth of enteric organisms, which would be all our gram-negatives that are our gut flora, and some of the gram-positive bacteria as well. This way, group B strep can thrive. And in fact, incubation in broth media increases the sensitivity by about twofold compared to direct plating. So a 50% increase in that sensitivity by adding this 18 to 24-hour step. And some of the recommended enrichment broths include the transvag broth, which is Todd Hewitt broth with gentamicin and nalidixic acid, again, to knock down that bacterial overgrowth. And very similarly, limb broth, which is Todd Hewitt broth with colistin and nalidixic acid. And even though it's selective, other organisms are found in these specimens and can still grow in this enrichment media. It just helps when it's enriched first, when it gets plated, in order to make sure at least group B strep has now been maximized. But some of the other organisms you see on the screen are well known to this laboratory, these laboratory groups that you see this, and we say, oh yeah, of course, those also grow on the plates and need to be ruled out. And recommended culture conditions with selective enrichment broth are things like, basically, so if you get an E-swab, you're going to take a 1 to 10 to 1 to 20 volumetric ratio of that specimen to the enriched broth medium, and that's going to get spiked into the broth medium, and that's going to be incubated for 18 to 24 hours at 35 to 37 degrees C. And another topic that we've been talking about is culture on solid media, right? So we have this selective enrichment, but we've been talking about that now getting put onto a plate, right? And so some of the acceptable augers that we would think about in the lab and that we use every day are things like a TSA, a tryptic soy agar, or a Columbia agar with 5% sheep's blood. And this is a non-selective, so you get a lot of growth. And you could see this actually if you look over on the right-hand side, you see this blood plate, this blood agar plate, right? That's got a lot of different colonies on it. And so that's indicative of that non-selection, right? So everything grows. Additional selectivity can be done with Columbia agar with colistin and nalidixic acid. So this is the classic CNA plate, and this is selective for gram-positive. So that helps group B strep stand out in its growth pattern versus the gram-negative. So you don't get overgrowth of gram-negatives. And then there's differential chromogenic medias. You can see one picture of a chromogenic media over on your far hand right screen, the one that's pink. That's basically a clear plate with the pink colonies growing. And so selected medias further reduce the growth of all that natural flora that are already in the specimen, right? And so it makes identification of group B strep a bit easier. Non-selective media also requires a high number of candidates for isolate screening, because the fact of the matter is that many of them during the overgrowth will be covered up, so you need a high number of colonies. Chromogenic medias facilitate GBS detection as well. You can see the picture on the far hand right again, right? But the thing is the issue is that many of those types of medias do not identify the non-hemolytic strains, which means you're not going to be able to identify those, and you have to fall back on another methodology, as we've been discussing. So you go back into the culture pathway anyway. And also susceptibility testing cannot be performed off of chromogenic media because it doesn't work. So that also leads to having to reset up the typical culture. And something else that we've been discussing is phenotypic identification methods. So when we think about phenotypic identification methods for group B strep from culture, we really range from what we currently do in most laboratories as MALDI-TOF, right? So MALDI-TOF is the mass spectrometry done to identify the colonies, but also for many years, or many of us are familiar with the other testing methodologies that we used. One is the Camp reaction, or the Christie-Atkins-Munch-Peterson reaction. And so this was prior to MALDI-TOF. And what was done in this case is you basically took Staph aureus, which is beta hemolytic, you struck it down the middle of the plate, and then group B strep would be at a perpendicular line. And what happens is, if it's in that perpendicular line to the Staph aureus, you'll see this extra increased zone of beta hemolysis that's due to this Camp reaction, right? Because they're both beta hemolytic. And so you'll see this hyper beta hemolytic, what looks like an arrow, right? And that's a really clear indicator that this is group B strep. It needs to be ruled out from Listeria. So what you do is basically you do a catalase reaction, and GBS is catalase negative. And one thing about this, though, it takes another 18 to 24 hours because it needs to be set up and time needs to be given for the beta hemolysis to occur. Another test methodology that was commonly done is latex agglutination. So this detects, if you look at the Lancefield group, so group B is in fact one of the Lancefield groups, and it detects the antigens that are on the surface of the organism. It's important to note also, if you get a positive with latex agglutination, so basically you did this test and it agglutinated, you need to be able to rule out other organisms that are also able to agglutinate. And so a PYR is frequently done and is negative for group B strep to rule out other Streptococcus species. And then, as I had already gone over, MALDI-TOF is our go-to today, and that is protein, really a proteomics fingerprint, primarily of the ribosomal proteins, that is indicative for group B strep and can differentiate group B strep from other organisms. And we also talked a lot about differential enrichment medias. So some of those ideas of like different broths, these are broths again that are enrichment medias. One is Granada liquid biphasic broths, and then there's carrot broth. So carrot broth, you can actually see in this picture, not surprisingly, it's orange like a carrot. You can see that group B strep that's positive is carrot colored, and a negative is non-carrot colored, which would indicate not group B strep. But it doesn't just indicate not group B strep, it indicates not beta hemolytic group B strep. So 5 to 6% of group B strep strains are not going to be beta hemolytic, and they are in fact going to show up as negative, but they are positive, which is why you need that backup culture in order to make sure that this is not group B strep. And so what you'll do is take that onto solid media for 24 hours to look for that. And pigment changes, if it does occur, the nice thing is that it's within 6 to 24 hours. So you can be really early that this can be called out as group B strep in the case that it is one of the beta hemolytic strains. So that's the plus of differential enrichment medias. And to go back, now that we've covered the traditional lab testing, to go back to workflows, the first one I want to talk about is the NAAT, the nucleic acid amplification testing, or the molecular workflow. So in that workflow, you get the swab in the lab, you can put it in differential enrichment media, and then you could run the molecular test directly off of that. And really, this is looking at even over the span of different molecular tests. Molecular tests really have demonstrated, and these are right out of the guidelines, improved detection of group B strep. And we're going to talk about some of those tests and some of those studies that have been done with those tests, right? But molecular tests can be set up right out of the guidelines in less than 5 minutes of hands-on time, and can be batched and be easily performed in the lab. One thing I want to point out in this slide, you see direct from specimen NAAT, again, is not recommended. So we're talking about NAATs that are done off of selective enrichment media. And really, it has really been shown clearly in the literature that when you look at molecular testing versus culture, molecular testing is by far the more sensitive option pretty much across the board compared to culture. Here's one study done looking at culture versus 3 different assays. We have the Panther Fusion GBS, we have the Gene Expert GBS, and the Aries GBS, and you could see that these 3 molecular assays range anywhere from 95 to 96% sensitive, where culture is coming in at about 73.5% sensitive. So you see that if you really look at what that means, false negatives in culture are basically, out of the study of 147 patients, it misses 39 of those 147 positives, true positives. So, And if you look at the molecular testing, you see that they miss anywhere between 5 and 6, but obviously the sensitivity is quite a bit higher. Another consistent look at the literature will show that if you look at culture sensitivity over various studies and you look at any molecular test, you see that the molecular tests range anywhere from a low of 90.9 up to 100% sensitivity, and culture goes anywhere from 53 to 73% sensitivity. So it's pretty clear that when you look at these collective studies, culture underestimates GBS colonization, and molecular testing picks up a lot more cases. And of course, this means that it leads to the potential to really reduce neonatal morbidity and mortality, because that's the critical part of actually doing any kind of prophylaxis or IAP. We have to know that GBS is there. It's the trigger to actually move forward with trying to avoid early onset disease. And so now back to susceptibility testing, because now we've talked about ID. So we've gotten through all the different modalities of whether we select, whether we do selective and differential, how we identify the organism, which methodology is more sensitive, less sensitive. Now let's talk about antibiotic susceptibility testing. So this is the last part of the equation, right? We still may need an antibiotic. So susceptibility testing is only performed in patients and mothers that are high risk, samples from mothers that are high risk of anaphylaxis, right? And so two common methodologies when you think about antibiotic susceptibility testing is you have your disc diffusion assay, which is your Kirby-Bauer on your left. This is when you have an antibiotic disc. That's basically, this antibiotic is infused into the disc, and that infused antibiotic gets dropped onto a lawn of the bacteria, which is struck out on the plate. And then you basically see if the organism can grow right up to the disc, or how close it can grow to the disc. If the antibiotic works, the organisms never grow, they die. So GBS dies. And so you see that zone of inhibition, which basically means the antibiotic works. If the zone is big enough, you can measure it and you say, okay, the antibiotic worked. Or it grows right up to the disc, and you know the antibiotics didn't have any effect on growth. Broth microdilution is a similar idea, with certain concentrations of antibiotics increasing in dilutions, right? So basically you have stronger concentrations, or if you look at it the other way, you have weakened concentrations, and you basically look at what concentration can kill the bacteria. So which concentration is going to kill GBS? And I think importantly, when you think about how to work up group B strep, a really important point to consider is macrolide-induced clindamycin resistance. So why this is really important is because clindamycin is the fallback for penicillin. So it's the first fallback. And what happens is erythromycin, macrolide, can actually turn on clindamycin resistance in some cases if the organism has that resistance factor. So in the presence of erythromycin, clindamycin that looks like it should work, sometimes it's shown that the organism, the GBS, is actually able to turn on a resistance factor. So I think it's a really nice visual looking at this, because while you can do this with broth microdilution, and there's FDA cleared automated tests, and really the go-to is if isolates are erythromycin resistant, but clindamycin susceptible or intermediate, they need to be tested for macrolide-induced clindamycin resistance. If they're sensitive to both erythromycin and clindamycin, then broth microdilution and regular AST methods are fine. But a nice test to do, and a common test still in the laboratory, is the D-zone test, right? And this is done to see if a macrolide, in this case erythromycin, could turn on resistance to clindamycin. And how that looks is like this. You basically put an erythromycin disc next to a clindamycin disc, and you streak the bacteria out, and then you put those two discs on a plate at a given distance from each other. If that erythromycin is able to turn on clindamycin resistance, what you will get is on the side with the erythromycin, where it is diffused out into the agar, those organisms will actually turn on their clindamycin resistant genes and will then be able to grow even closer to the clindamycin. So you see this line where basically those organisms just have marched forward into the circle and have started towards the clindamycin. And at that point, you know that you have a positive, and the reason it's called a D test is because it looks like a D. And at that point, you know, okay, clindamycin is not useful in this case because even though it looks sensitive, it is in fact not sensitive, and it will be induced to be turned on and will not work clinically. Also, I'm sure that you're probably thinking, you know, erythromycin is kind of interesting, right? Because we're testing erythromycin. Well, what happens if erythromycin is sensitive, right? Well, actually, erythromycin fell out of favor because of high resistance, and we'll talk about that in a bit, what the resistance is. It really has high resistance and unreliable performance for decolonization. So the current guidelines no longer recommended for IAP, but it is very useful to see if clindamycin can be induced for resistance, which is why it's still used in this particular case. And in fact, when we talk about global patterns of antibiotic resistance in group B strep, it's very clear penicillin is still the go-to at a susceptibility rate. 99 to 100% of organisms are sensitive to penicillin, of GBS organisms. So group B strep is exquisitely sensitive to penicillin. It's also exquisitely sensitive to vancomycin, but vancomycin is our last go-to drug in our arsenal of antibiotics, and it's not one we use just readily because we don't want to develop resistance and just because it also has other off-label effects that that are not good. So erythromycin, again, this points out what I had just said about the susceptibility rates, about being 50% susceptible, 50% resistant. So it's really not the go-to anymore. And clindamycin still has susceptibility in anywhere from 63 to 72% of cases. So clindamycin, when it is susceptible, is still a good go-to as a backup. It's not better than penicillin. It's just the go-to for penicillin when a patient has penicillin allergies. And so now that we covered that, we think about the different turnaround times for screening methods. So when we look at the different methods we discussed today, molecular testing takes about a day because you basically spike the enrichment broth, and then from that, you can run the molecular test the next day. Differential broths are great in some cases because, for example, the carrot broth can turn orange very quickly, right? And this could even be in as short as 10 hours. But the issue is that the non-beta hemolytic strains still need to be parsed out if they're there. And this can take up to 3 days. So quick positive answers are quick. Positive answers that are non-beta hemolytic are not quick, and negatives are not so quick to actually parse out. And then you have selective enrichment broth with culture, and this can take 1 to 2 days, depending on whether we see beta hemolysis the first day or the second day. And so we've been talking about group B strep screening this whole webinar, right? I think it's really important to go back and look at why group B strep screening has been such a success. And this all starts back in the 70s, right? So back in the 70s, group B strep emerged as what was clear to be a pathogen, right, and a leading cause of infant infection, right, leading to early onset and late onset disease. In the 1980s, studies were done looking at IV antibiotics during labor that could potentially prevent invasive disease in newborns, and they worked. And so then going into the 90s, recommendations came out from the CDC, from ACOG, trying to move forward interpartum prophylaxis. And the consensus guidelines between ACOG, AAP, and the CDC were first released in 1997. And then universal screening was adopted in 2002. And that brings us up to present day where the guidelines are transferred to ACOG and ASM and AAP. But when we go back to what this did, right, when we look at this timeline, there's a couple things I want to point out. You can look at the graph on the left, which is total group B strep early and late onset infections. You could see that light blue line is early onset. And you could see from 1997, when the consensus guidelines were put in place, to 2002, when universal screening happened, you started to see a drop, but that drop really happened precipitously between these two events. The guidelines and then universal screening, which continued to drop. So first was the guidelines to treat, and then universal screening led to finding more cases, and you continue to see this drop. And this is reflected also on the right-hand side when we look at rates of GBS, early and onset infections per 1,000 births. You see that same trend. And so, I mean, Group B strep screening has been an enormous success story, right? And it has been successfully implemented in the United States and has led to an 80% reduction in early onset disease in newborns. So that's a tremendous reduction in disease. But this is not just a story of the United States. This is actually a global success story because we can look at studies in Australia and the UK. Here's two examples. A study done looking at period before implementation of GBS screening and then afterwards. From 1994 to 2002, the early onset disease rate for GBS was 0.84 in 1,000 live births. After implementation, a 2-year implementation, it dropped from 0.84 to 0 cases of group B strep disease, early onset disease, in 8,303 live births. So 0 cases. In the UK, from 2009 to 2013, they had an early onset disease rate of 0.99 per 1,000 live births. During a 1-year study looking at GBS screening, they dropped that to 0.16 in 1,000 live births, which translates to a 5-fold lower rate of group B strep early onset disease. This is also played out in other places globally. Another example is Taiwan. So Taiwan in 2012 initiated maternal GBS screening, and they had a very high rate at 2.8 cases per 1,000 live births. And after implementation, they saw a drastic drop, and in fact dropped by 2016, dropped to 0 cases of early onset disease in 2016. So again, an enormous success story. And when we look at the key takeaways from all of this information, I think it's pretty clear that group B strep infections have a serious long-term negative health consequence for mothers, for newborns, and this is found in early onset disease, but it also is found in maternal health, neonatal health, and also overall devastating effects on families who go through these types of awful scenarios that happen. It's clear that IAP is a really effective intervention for prevention of early onset disease in neonates. But of course, IAP is, for the most part, driven by detecting group B strep, right? And so CDC, ACOG, AAP, and ASM all endorse universal group B strep screening of pregnant women to inform the use of IAP and also aid in the prevention of early onset disease. With better detection than culture, it's pretty clear that molecular tests have the potential to further reduce what's already been reduced by finding more cases of group B strep. More mothers can be treated with IAP and lead to even further driving down neonatal morbidity and mortality due to early onset disease. And implementation of universal GBS screening in pregnant women has successfully decreased the burden of early onset disease in many countries, and those were just a few of the studies that I had just shown. So it's an enormous success story. So with that, I would like to thank everybody so much for joining me today for this webinar, for having this important discussion. I hope that you found it informative, and I really enjoyed being able to be here with you in the audience for this lab week. Thank you all for the fantastic work you do in our laboratories. I just think that, the diagnosis starts with the lab and is the lab is the major driver of these things. And I think group B strep is a perfect example that when the lab identifies group B strep, this leads to a mother getting the right treatment and leads to a healthy baby and a healthy mother. And it's really critical upon the lab result to find that. And so happy lab week, everybody. Thank you for all the work you do. And I'm so happy I was able to join you for this. Thank you.